All right, hello and welcome to the Western Victorian PHN's Project Echo Hub. This series is about intellectual disability, information and education, and is part of the Spider Echo Network. So today is Tuesday, the 21st of June, 2022. This is the fourth session in the series, and we've called this session Consent and Decision Making in 2022. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we're all zooming in from today. We recognise their diversity, resilience, and ongoing place in the First Peoples hold in our communities. We pay our respects to the elders, both past, present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations, and we will work together on closing the gap. My name's Robert Ward, and I'm the GP facilitator for this Echo series on intellectual disability. I work as a full-time GP in a group practice in Geelong. My oldest son is 25 and he has an intellectual disability. So intellectual disability affects 450,000 Australians, and it is recognised that they have poorer health outcomes than the general population. These Echo sessions are designed to generate conversation and ideas we can employ in our practices to achieve better health results for this population, assisting them to access or to better access better healthcare. The sessions are organised by the Westvic PHN Spider Project team, which was set up in response to the federal government's national roadmap for improving the health of people with intellectual disability. The report launched in July last year. These meetings are fortnightly, and this is our fourth session to date. So far, we've discussed the diagnostic pathways of intellectual disability, the concept of reasonable adjustments, and our last session was on communication. Each fortnight, we've been joined by experts in their fields, and today is no exception. So we'll have the opportunity to explore this important topic of consent and decision-making with them. So the concept of consent and decision-making capacities are fundamental to many aspects of general practice. The GP should be the health professional who most understands the patient's capacity. We should be able to advise and be actively involved with working with other professionals in this area. Whether it is consent for a flu injection, referral for surgery, or discussing with a care provider a patient's ability to consent or to refuse treatment. What is valid consent and what to do if a patient can't give consent? We should be able to use our skills in communication and reasonable adjustments to make sure our patients have the information they need to make the decisions. If appropriate, we should also have the ability to respect and support our patients' decision-making process. So today is a really important subject. So I'd just like to start with just an introductory slide just on the meeting today. So our number one aim is to build a community of practice in these sessions. And the best way to do this is if we can see, hear and interact with everyone. So if we can keep videos on and audio on mute when you're not speaking, check that your name has been added appropriately. I'm going to go around the room and just to introduce everyone live. So if you can be ready just to say hello. There's a chat function there, so please use the chat just to provide a few more details about your role, where you come from, interests, or anything you want. You can ask questions or reflections through the chat and make recommendations and highlight resources during the chat. We'll monitor the chat throughout the session. I'd like to remind people about privacy. The didactic session will be recorded and the video and audio will be published on the Westvic PHN's website and the YouTube Learn page. So if you don't want to be visible, turn your camera off and we'll please maintain patient confidentiality at all times. So I'd like to introduce everyone. So firstly, I'd like to welcome the Westvic team, the presenters and the panel members who are going to help us discuss the concept of consent and decision-making. So I'd like to just introduce the Westvic Project Echo team. So I think Gemma and Whitney are around. Just give us a wave. They're in the blue squares there and they're going to help us in the background monitor the chat and they help organise these sessions. So thank you very much, guys. There's the members of the Spider team are here. I think Kerry was here. I'm not sure if Nicole had arrived yet. So welcome to them.
Good morning, everyone.
Good morning. So our didactic presentation today is going to be by Katie Riceputo, who's the Education Engagement Officer with the Office of the Public Advocate. And Katie will be presenting around the topic of consent and decision making. Do you want to just say hello? Hey,
Hi,
Katie,
everyone.
just
Good
to
morning.
let everyone know who you are. Welcome today.
Thank you.
So, and to help us discuss the important subject, we have our expert panel members. So a bit of a regular is Jane Tracy, who's the General Practitioner and former Director of the Centre for Developmental Disability at Monash Health. Hi, Jane, and welcome.
Thank you, Robert.
We also have Naomi Anderson, who's the Principal Solicitor at Villamanta Disability Rights Legal Services.
Good morning.
Hi, Naomi, welcome.
Morning.
We also welcome Evelyn Culnane, who's the Manager of Transition Services at the Royal Children's Hospital.
Hi,
Evelyn, do you want to say hello? Hello.
Hi.
And Professor Lynn Gillam, who's the Children's Bioethics Centre, Royal Children's Hospital Department of Paediatrics. Lynn, do you want to say hello?
Morning, everyone.
Hi, Lynn, and welcome.
Thank you.
And today we're going to have a case presentation by Sonia Gardiner, who's the Senior Medical Treatment Decisions Officer at the Office of Public Advocate. Sonia, do you want to say hello there?
Hi, everyone, and apologies for such a long title.
Oh, that's all right. So I'd just like to go around the room and say hello to people. If I call your name and if you're available, just to say hello. We've got Varel there. Welcome, Varel. Varel's our practice manager, and she's probably very busy doing something at the moment. Andrew Giddy.
Well, good morning, everybody. Andy Giddy from Westvic PHN. I'm a sponsor of the SPIDER project.
Welcome to our session today, Andrew. That's terrific. Kevin Chang is here. Kevin, are you able to take yourself or to say hello?
Hi, morning.
Good.
Yeah, I'm Kevin. I'm one of the GPs at Wadawurrung Aboriginal Co-op.
Welcome today.
Thank you.
It's an important subject today, so it's going to be great to talk about. We've got Gail Schuler. No, Gail's still hidden away there. Welcome, Gail. There's Monica.
Good morning, everyone.
Good morning, Monica. And where are you from, Monica?
I'm from Victoria University. My name's Monica Wellington.
Hi, welcome today to our session.
Thank you.
And Kiera is up there. Hi, Kiera.
Hi, I'm a psychologist in the autism assessment team at CAMS and also in private practice.
Welcome today. And as always, John Newman joins us as well. Hi, John.
G'day, Rob, everyone. I'm a GP in Geelong West.
Welcome today. Have I missed anyone? No one else wants to say hello? Well, welcome, everyone. So I think we'll just put the agenda slide up just quickly. So we'll have our didactic presentation. Our panel members will help us discuss it. I really want to get into the case presentation today from Sonia and to allow us to spend a bit of time to discussing the case. I'd like to just remind people about the case studies presentation. It's all about case studies. So if you have an example of anything you'd like to discuss at any of the future echoes into next term, that'd be terrific. So you can just log on to the site there, and we can arrange for those case studies today. I know this has been a popular one for case studies today. It's such an important subject. And I'd also just like to remind people about the professional development. So there's the opportunities to get some points and to just improve your professional development. So if you want to contact the workforce development team via what's on the slide, would be fantastic. So I'll quickly go through our learning outcomes as we do each week for this series. To recall the terminology used when describing intellectual disability and developmental disabilities, identify solutions that support primary healthcare to deliver high quality healthcare tailored to the individual needs of a person with an intellectual disability, to assess the disparities in the health inequities in our system, discuss the United Nations Convention on the Rights of a Person with an Intellectual Disability, and to summarise the important reasonable adjustments that we can implement in primary healthcare.
Can anyone else hear Robert?
No, I've lost his sound too.
Yeah.
I think you've put yourself on mute somehow.
I think it's his connection because he's frozen.
He's gone. He might reconnect.
He'll come back again, yeah.
Yeah. Well, these are the learning outcomes for this session anyway. So understand the right to consent.
Hello, I'm back.
Oh, you're back.
Can you hear me?
Yes. Yes.
I'm not hearing anyone. Sorry about that.
Can you hear us now, Robert? Can you hear us? No. Okay.
Hi, can anyone hear me?
Yep.
I'm back.
Can you hear
But my sound is
us?
terrible, I think. Yeah, I'm freezing there. Sorry about that. I hope someone can take over. I might just try to move somewhere else.
That's all right. Yeah, well, we'll go through the learning outcomes for this session. So understand the right to consent or refuse medical treatment. Identify the definition of decision-making capacity. Identify substitute medical treatment decision makers. Understand the process of seeking a decision by the Victorian Public Advocate through a Section 63 form if a person does not have decision-making capacity and there is no identified substitute decision maker. So stop sharing. We'll go on to our didactic presentation. Katie's presenting that today, and I think she was going to share her own slides.
Yep, I'll just get that happening now.
Thank you.
No worries, thank you. Okay, can everybody see that presentation okay?
Yeah.
Excellent. All right, thank you. So again, thank you for the introduction before, Robert. My name is, as you said, my name is Katie Riceputo, and I am the Education and Engagement Officer here at the Office of the Public Advocate. And Sonia talks about her title being a tongue twister, but that sentence was a tongue twister as well, so I apologise for that. I'd also like to acknowledge the traditional owners of the land on which we are meeting. We pay our respects to elders past, present and emerging, and extend that respect to any Aboriginal people who may be present. So today I'm going to do a brief introduction into decision-making capacity and the medical treatment decision-making, as was outlined in the learning outcomes. Some of these slides I won't go into too much detail as I only have 10 minutes, so but there are others that I will go into more detail. So we might start with decision-making capacity. So legislation actually states in Victoria that an individual is presumed to have capacity unless there is evidence of the contrary. So when we look at what is decision-making capacity, generally speaking, a person has decision-making capacity when they are able to demonstrate these four aspects. So firstly, they are able to understand the information which is given to them that is relevant to the extent of the decision that needs to be made. They are able to retain that information to the extent necessary to make that decision. They're able to then use or weigh up that information as part of their process of understanding the information and then therefore making the decision. And then finally, they are able to communicate their decision in some way. So we may have instances where an individual with a disability may be non-verbal or cannot express themselves verbally, but that does not mean to say that they don't have decision-making capacity. So it's about trying to understand other ways in which that individual could perhaps communicate their decision. So most commonly, I guess, will be communication devices, having them write, information down or their decision down. So it's about being, a holistic approach and finding other ways that can allow that individual to communicate their decision. So the new legislation which came through in 2016 has really shifted from best interest to values and preferences. So it's, before 2018, or, really there was a medical power of attorney, but since then you are able to appoint a medical treatment decision maker, you're able to make an advanced care directive or appoint a person for their medical treatment decisions. So again, I really want to make it important, or place the importance on the fact that there's this shift that has gone from best interest to values and preferences. So in previous legislations, I guess generally speaking, a decision maker would have gone, well, this is what I think is best for the individual, and I'm going to make those decisions based on what I think is in their best interest. Whereas a current legislation really looks at, well, hang on, no. What is the values and preferences of that individual in making their own decision or being part of that decision making? Is there any additional practical and appropriate supports that can assist that individual to make their own decisions? So it really has gone away from separating that individual to allowing that individual to participate in their own decision making. So we look at an advanced care directive. Advanced care directive is one of the ways or forms that an individual can express their values and preferences, that if in the event that one day they're no longer able to make decisions for themselves, they have put that in writing and they have expressed what their values and wishes are. And the advanced care directive is split into two sections. So there's the values directive, which looks at the preferences and values, and an instructional directive, which is legally binding. So values directive is a statement, I guess, of a person's preferences and values as the basis on which they would like any medical treatment or decisions to be made for them in the future. Whereas an instructional directive is a statement of a person's medical treatment decision that is directed directly and specifically to the patient's health practitioner. So an advanced care directive really is to inform any future medical treatment in the event that that person is no longer able to make decisions for themselves. So not-for-resus is one of those things that really come up a lot. And I guess the advice that we always provide people is that CPR or not-for-resus is a clinical decision. So if the clinic or the clinician feels at that time that not-for-resus or the resuscitation is futile or non-beneficial, within the legislation they are not obligated to perform CPR or to resus a patient. So that's really important to keep that in mind. Of course, when we're talking about not-for-resus, it's such an important decision. It should have a discussion and involve discussions with family and or medical treatment decision maker. The doctors, as I said, are not required to perform CPR or to resuscitate somebody if they feel that the resuscitation would be considered as futile and non-beneficial. And the family members should not be pressured to complete their forms. So unfortunately, there are situations where, I guess, service providers or aged care facilities have it as a stipulation that for them to access that service, they are to complete an advanced care plan or a not-for-resus plan. I digress a tiny bit, but this is just happening to my grandma right at the moment, actually, with her service provider. So it's really important to know that it's not for their, form filling exercise that someone should feel pressured to complete these forms. It is an individual choice, but what's really important is that their GP is involved where possible and has those conversations with the family members and in turn has those conversations with providers or aged care facilities around, well, this is what would happen if in the event. But again, members of the family should not feel pressured to complete these forms. So if we look, I'm not going to go into too much detail into this slide, but this slide really just provides you an overview of the definition of medical treatment. And really the Act stipulates that it is in two parts, and it is for the purposes listed below and for one of the forms of treatment. So we look at medical treatment and it is either what is the purpose of the treatment and what is the form of the treatment. Okay, so just really quickly, the purpose could be diagnosing a physical or mental condition, whereas a form of treatment is treating with physical or surgical therapy. So again, emergency treatment, as defined in the Act, is to save the person's life or the patient's life, to prevent serious damage to the patient's health, or to prevent the patient from suffering or continuing to suffer significant pain or distress. So I will go into this a bit further when we talk about identifying a substitute decision maker, but for the medical practitioners, it's important to know that if you define, so the medical practitioners are the ones that decide or determine whether a treatment, impending treatment, is emergency or not. We do get quite a few calls from medical practitioners on the advice service asking us whether it is defined as emergency. So we're not the ones to determine that. So if you determine that a treatment is emergency, then consent is not needed. So you need to be very clear as to why it would be considered as emergency or why it's not considered as an emergency. And the definition gives you a bit of a guide as to whether you feel that treatment is considered as emergency. So again, consent is not needed if it is considered to emergency treatment. But however, if the health practitioner is aware that a patient has refused that specific treatment and it is stipulated in their instructional directive, then they must not proceed with the treatment. Okay, so even though consent is not needed, if that patient has stipulated that specific treatment that they want to refuse in their instructional directive, then the doctor must not proceed with that treatment. So palliative care is another aspect of medical treatment that also, you know, it is a tricky point at times. So if a health practitioner administers palliative care to any person, then he or she must, excuse me, have regard to any preferences and values of the person, whether expressed by way of values directive or otherwise. If the values and preferences are not known for whatever reason, then that individual needs to make decisions based on what is, you know, best to promote their social and personal well-being. And in administering palliative care, there must be consultation with the person's medical treatment decision maker, if there is one. So the definition of palliative care, I guess, really looks at the provision of reasonable medical treatment for the relief of pain, suffering and discomfort, and the reasonable provision of food and water. And palliative care, or to palliate someone, is also consent is not needed. So when we look at when an individual does not have decision-making capacity, so we've looked at some of the forms that an individual can do if they do have capacity, and that is they can appoint a medical treatment decision maker, they can complete an advanced care directive, and they can also appoint a support person. But where a patient lacks decision-making capacity, these are the steps that a medical practitioner or medical treating team will need to go through to determine who is that patient's substitute decision maker. So number one, is there an advanced care directive or relevant to the specific decision? or have they appointed a medical treatment decision maker? If not, then there would be, I guess, plans to try and see if there is a guardian appointed by VCAT to make medical decisions. And then if there is no guardian appointed for healthcare or medical decisions, then the medical treating team would need to look to this list. So this is section 55 of the Medical Treatment Planning and Decisions Act, this whole slide here. So this list is a hierarchy where we look at, is there someone on this list that the medical treating team are able to look to provide that decision, to provide that consent or refusal of that treatment? Well, the first person on the list is a spouse or domestic partner. If there is a spouse or domestic partner and they are in a close and continuing relationship with that patient and they're willing, able and available to make that decision, then the medical treating team will look to that person for that decision. If there is no spouse or domestic partner, then we keep going down the line. So is there a primary carer? And when we talk about a primary carer, we talk about not a paid carer, okay? So a primary carer, if there is no primary carer, then we look to the next person with an adult child. If there's more than one adult child, they will look to the eldest child first. And again, if they are in a close and continuing relationship with that patient and they are willing, able and available to make that decision, then they'll look to that person. If there is no adult child, then we look for a parent. Is there a parent available that is able to consent or refuse to that treatment? And if not, then an adult sibling. And again, if there is more than one sibling, then they would look to the eldest first. But again, really, really important, if looking at this list, the medical treating team will need to determine satisfactorily that that person, if there is one of those people on that list available, that they are first in a close and continuing relationship with that patient and they are willing, able and available to make that decision. Okay, so just a bit of an extension to that, I guess, where a patient lacks capacity and there is no relevant instructional directive in an advanced care directive and there is no medical treatment decision maker, then these are the next steps. So firstly, the medical treating team will need to determine whether the treatment or the impending treatment is considered significant or routine. So I might start with significant first. So significant treatment basically looks at whether the impending treatment may have some significant side effects for that patient, where that treatment could potentially have significant, cause significant distress to that patient, and also may have significant bodily intrusion to that person. So for example, generally speaking, if a patient is to undergo general anaesthetic, that would be considered a significant treatment. But even something simple like a blood test or an MRI, for example. So an MRI, on the surface, we may think, well, it's just a scan. It doesn't really seem to be significant. But if you've got a patient who is claustrophobic, for example, and may need a sedative to be able to have that MRI, then that would be considered as significant for that person because it could cause significant distress for that individual. So significant treatment or routine treatment is not looking at that treatment specifically, but it's looking at that individual and how they would react to that treatment. So again, like blood tests, for example, someone may have a severe phobia of needles. So a simple blood test, or what we might consider as a simple blood test, is not simple for those people. So that would be considered also as significant treatment, okay? And routine, so aptly defined, is anything that is not significant. So if the treatment is routine for that individual patient, then consent is not needed and that treatment can go ahead. If it is significant treatment and the medical treating team were not able to identify a substitute decision maker, then a decision must be obtained from the public advocate. And that is done by a section 63, which is a form which is found on our website and it can be submitted online. And then that form will go to Sonia's team. But what's really important about a 63 is that the doctor, who is going to perform that treatment needs to be very clear in that form and demonstrate very clearly that that person, because of their disability, is not able to make decisions for themselves, and to also demonstrate quite clearly how they have not been able to identify a substitute decision maker. So Sonia's team needs to know very clearly on that form the processes that they've taken to determine that, yes, there is no substitute decision maker, yes, this is a significant treatment, and yes, we need a section 63 completed, and we need one of your team members to triage that accordingly and to make that decision. So if the treatment is routine, as I said before, the health practitioner can proceed without consent, and that is section 56 of the Act. Okay, so there are situations or circumstances where a guardian for healthcare is needed, and these are the situations where a guardian may be needed. So there's no legislative, it's really 7:30 in the morning, it's a bit difficult to say legislative restrictions on how section 63 can be used or over what length of time, where the medical treatment decision maker disputes to recat their exclusion as medical treatment by the health practitioner, and where there is complexity and frequency or need for more advocacy or oversight interventions in order for decisions to be enacted. Guardianship may be warranted. Okay, so this slide just really looks at a summary of the steps that we've gone through already. So when a patient is unable to consent or refuse treatment for themselves, then the first step is we'll look to see if there's an advanced care directive or instructional directive. If there is, then the medical team need to give effect to relevant instructional directives. If there isn't one, then a medical treatment decision maker needs to be obtained, or to see if the patient does have an appointed medical treatment decision maker. If yes, then that person can make the decision for that patient. If not, if there is no medical treatment decision maker appointed, then it looks to see whether the treatment is significant or routine for that patient. If it is routine, then treatment can go ahead without consent. But if it's significant, then the public advocate can come on board to make that decision via a section 63 form. So that brings my little presentation formally to a close. There are some resources that we have on our website. These are the Advanced Care Directive form and the appointment of a medical treatment decision maker form, which are available on our website. But the Can Your Adult Patient Consent flowchart is a wonderful resource. Personally, I think it's probably one of the best resources we have on our website, especially for medical practitioners, because it really clearly identifies and outlines in a very succinct and clear process how to identify a substitute decision maker, or how to obtain consent if the patient does not have decision-making capacity. So I do urge everyone in the medical field to grab that flowchart. As I said, it is a wonderful resource. So that brings my presentation to a close, and I welcome any questions, and yeah, please feel free to ask any questions if you have any.
Thank you, Katie, and apologise about my internet connection before. Thanks for that wonderful presentation. I noticed that slide that you had at the end is also available in an app.
Pardon?
That last slide is also available in an app, which I've got on my phone for decision making. So it's a good little flow chart for people to download.
Yes.
So I wonder if anyone had any sort of comments or questions for Katie at the moment.
Great. You can ask all your questions to Sonia when she does the case.
Certainly the case study might bring some, but also note that sometimes things we do in general practice, we don't seem as significant, but for the patient, particularly someone with an intellectual disability, are highly significant, even to the point of, just giving a flu shot can be quite significant to patients, or even just taking medication. So maybe someone deciding not to take a medication, and maybe that has a huge consequence, not just for the patient, but also for the care provider as well.
That's right. And I did also want to say, Robert, that we do have a dedicated medical line on the advice service as well. So if anyone has any questions, or they want to unpack any scenarios, or they're not sure whether, it is, even though the medical team need to determine who is an appropriate, decision maker on that list, or whether the treatment is significant or routine, that does not mean to say that they still can't call us and unpack that anyway with us, and we can help you, and guide you through that process. So, you're not, medical practitioners are not on their own. We're not saying that they need to make all the decisions, but that's what we're here for. Mm-hmm. And we're always willing to, to unpack something further with them.
Yeah, and John's got his hand up there. John, do you have a question?
I just was interested, if you submit the S63 form, what sort of time frame is that turned around and dealt with?
I'm going to answer that question. Yeah, thank you. So, John, there's never going to be a hard and fast answer to that. It may help you to know that there's only 3 of us that cover the whole state. So the resources Monday to Friday, 9 to 5. We always try and meet a time frame that's presented, but a lot of hospitals, for example, may submit something at 9 o'clock and we want them on the table at 12 o'clock. That's generally not a time frame we can meet because of the legislative requirements that we then have to undergo. So we may be talking to them about what emergency treatment means and needing to get away from that concept that emergency treatment is someone who's bleeding out in the ED and they need to save their life, but it does actually have 2 other components to it. So we would ask the sooner the better, really.
And Varel's put in the chat about someone presenting to a vaccination clinic who's not known to the practitioner. Mm-hmm. How do we determine consent or capacity for consent?
Yeah. Look, I suppose, again, you're going to have to look at your timeframes for that, but you may not know the patient, but I assume as a starting point, you're talking to the patient about, well, what the vaccination is, the risks, the consequences, what the side effects may be. In order to then have that discussion with the patient to see are they demonstrating that they've understood that, remembered what you said, and explain what they think is important or not in making that decision. So there's nothing that stops you from doing that the first time you meet a patient compared to the 12th time that you're meeting a patient, and also noting that capacity is decision specific. So they may have capacity to make this decision, but not a subsequent medical treatment decision. Depending on your time, you may then have the time to ring their accommodation provider, or if they've got family or somebody else who may know the patient, who then can maybe kind of substantiate some of the information that you're asking. That the obligation around assessing decision-making capacity sits with a health practitioner. The Act doesn't say that has to be a neuropsychologist, psychiatrist. It has to be someone who knows them for 50 years, a health practitioner.
Okay. I'd really like to keep going, but I think we're sort of really running out of time because it's nearly 15:15. So I think in the chat they've put a connection to the evaluation slide. And look, I'd just like to thank everyone for turning up today. I'd like to thank Katie for her presentation, for Jane, Naomi, Evelyn and Lynn for their contribution, and for everyone for attending. I'd like to just remind you about the Health Pathways with some information about intellectual disability, and to remind you that this is our final echo for this particular series. And so we're going to be back on Tuesday, the 19th of July to start the next series. And we're going to revisit reasonable adjustments. Oh, there's a slide there about the spider team. I don't want to forget about the spider team. So thanks very much, everyone, for joining us today. It's been a really interesting topic, and I'd really want to revisit if our panel can come back again another time. I think it'd be fascinating to have a bit more time to discuss things. That would be brilliant. So thank you very much, and everyone enjoy their day.
Thank you.
Thank you.
Thanks, everyone. Bye-bye.